Hello, everyone. My name is Dr. Martha Gulati. I'm the Director of Prevention at Cedars-Sinai in Los Angeles at the Schmidt Heart Institute, as well as the Associate Director of the Women's Heart Center, the Barbara Streisand Women's Heart Center. And I am also the president currently of the American Society for Preventive Cardiology. I'm really excited to be here with you today. So let's just get to your questions. Yeah, so in patients who have familial hypercholesterolemia, we know that the age of first cardiovascular event is actually similar for women and men. This is actually in contrast to the general population, because in the general population, generally women tend to have cardiovascular events later, by about a decade, compared with men. So there is something unique about FH, that there isn't that decade lag in acquiring cardiovascular disease. So why does that happen? Well, first, women are often diagnosed later than men. And even once women are diagnosed, women receive less lipid-lowering treatment compared with men. And as a result, women have higher LDL levels. Additionally, for women, there are periods that occur where women might not be under treatment. What do I mean by that? I mean, during pregnancy, during breastfeeding, often treatment stops at that time. And on average, it's estimated that about 2 years are lost during those childbearing times, sometimes much longer. And as a result, women have a higher cholesterol burden, even when they maybe have been already initially under treatment. So that's why women who have FH actually do worse than men, and it's a reason for us to be rightly concerned about that. I would say that the answer to this is relatively unknown. You know, Lp(a) is something that we're just, I think, at the earliest stages of really understanding. And for that reason, I think we don't know a lot of the answers related to this specific question. What we know is that for men, Lp(a) generally stays consistent through their lifetime. But for women, actually, there's times in life where Lp(a) actually increases. The ones that we know of are during pregnancy and after menopause. So, you know, specifically related to estrogen related diseases like endometriosis, polycystic ovarian syndrome, we just don't know. We just don't have the data. So what we discuss with young teenage girls, and I do see some young teenage women, where I counsel them on heart-healthy diet patterns. So we talk a lot about plant-based foods, vegetables, fruits, whole grains, legumes, healthy protein sources that they can incorporate into their lifestyle. We talk about limiting sweets and sweetened beverages, as well as red meats. And we also talk a lot about exercise, because exercise is essential. And we know that as people age, we end up doing less exercise. But we really need for young teenagers to understand how that should not happen to them, that they need to keep a very active lifestyle throughout their life. I counsel them on types of diets. And, you know, the first is meeting them where they are, because understanding what they're eating and where they are in their life. So what I mean by that is, if they're a college student and they're living on campus, I think one of the food groups is pizza at a college. And I say that tongue in cheek. I don't think that is a food group, but trying to help them make healthier choices when they're in crowds is certainly part of what we counsel them on. But also finding places that we can implement better changes for them is incredibly essential. Also for teenage girls, I mean, it is important to talk to them about the future and talk to them about maybe future pregnancies. It may not be that they're going to get pregnant right here and now, but talking to them about that for the near future is really important. So I do think, though, in addition to lifestyle, I do talk with both the patient and their parents about early statin initiation. The sooner we start, the more likely that they've had years of lower LDL. So it almost helps us be okay with the potential interruptions in therapy that happen in most women who have FH. The current guidelines actually call for the initiation of statins in children around the age of 8 if the LDL is already above 190 milligrams per deciliter, particularly if there's already a family history of heart disease. Yeah, so when they have FH, and if there's the potential for them to get pregnant, I talk to them about using a non-hormonal device, an intrauterine device. And if that isn't an option or not something desired, then the next choice that I discuss with them is a progestin-only contraceptive. The combined hormonal pills, they can be used, but there is a theoretical increased risk that outweighs the advantage with estrogen-containing contraception. So they may increase the risk of atherosclerotic cardiovascular disease. It's also estrogen specifically tends to raise triglycerides, but may also raise the LDL in women. So that's the reason that we don't really want these medications on patients who have FH. It's not to say that sometimes the choice made by the patient will be that they want the combined contraception, but this is a shared decision-making moment. What we know the most about is genetic counseling related to FH. And I would say that if a woman has FH and she's considering pregnancy, her partner needs to be tested for FH as well, because both of their statuses are going to affect the offspring. Assuming her partner doesn't have FH, then each child of that mother with FH will have a 50% chance of inheriting the condition. Ultimately, though, if both parents have FH, the child itself has a 25% chance of having homozygous FH and a 50% chance of having a child with heterozygous FH. So, prenatal counseling is important. Risk discussions, ensuring the couple's aware of these implications is very important. And it's really true if any partner has FH. So I know I deal with a lot more women, but even if a man has FH, I make the same recommendations that his partner needs to be screened, because ultimately it's going to affect their offspring. For Lp(a), we know a little bit less in terms of, getting genetic counseling. Is that helpful or not? But again, I think the same approach is reasonable, meaning that when one partner has elevated Lp(a), we know it's genetically shared. And what we need to know is also, what about the other partner? Do they have elevated Lp(a), or do they actually even by chance have FH? They need to get those things screened so that we know what we're dealing with. And I think genetic counseling can be a very useful tool for a parent and the parents to know what is going to be the effect on the potential offspring, because those are decisions that that they may not have even considered. Our guidelines about stopping statin therapies are pretty consistent. Somewhere between 1 to 2 months before pregnancy, we recommend stopping statin therapy, then stopping the birth control if they are on a birth control, and then trying to conceive. So in terms of what we For individuals, particularly those with homozygous FH, for those patients, we actually need to have the discussion even beforehand is, are we going to stop statin therapy or not? Because for some patients, it may not be safe to stop statin therapy. Maybe we'll switch them to a different statin, one of the more safer statins that we don't have any teratogenic risk is some of the hydrophilic statins like pravastatin. So sometimes we'll make a choice based on that. For other patients, they'll decide that they do not want to be on statin therapy. They don't want the risk of exposure to statins for their fetus. If that's the choice they make, then I think everything else applies the same. Now, during pregnancy, again, personal choices, particularly for our homozygous FH patients who might want to stay on statin therapy. In 2021, the FDA actually removed the strongest recommendation against using statins during pregnancy, so we can in certain patients, but for many people, they will choose to not be on statin therapy while they're pregnant. During breastfeeding, there's actually no specific recommendations for breastfeeding for patients with FH. Right now, the World Health Organization recommends exclusive breastfeeding for the first 6 months and then continued partial breastfeeding even up to the age of 2 years. We know that our patients with FH definitely breastfeed less than the general population. We've seen from a number of studies in Norway and the Netherlands where women will not breastfeed as long as women who don't have FH, and probably because they've discussed with their physician about, being not exposed to statins and then the potential for elevations in their LDL and how long do we expose people to high LDL levels. I will say that admittedly, the general population, there's a lot of pressure on women to breastfeed and almost guilt to women when they don't breastfeed. But I think that the way that I communicate this to my patients is your child needs you there. We don't want you to have a cardiac event. Breastfeeding is only part of the equation to a healthy child. You need to be healthy too. We know, as I already mentioned, that we lose a lot of time during pregnancy, a lot of treatment time, of low LDL time, because during pregnancy, often women choose not to take statin therapy. So if we add that time and the breastfeeding as well, we're even extending that exposure to elevated LDL. So I think that these are things, again, to talk about with your physician, the person who's managing your FH, and to talk about what is the best thing for you and the best in terms of your personal wishes, your personal desires, but also to get the additional information about how long will you be without a statin therapy or other medication therapy to really keep your FH under control. And that comes to the other point, the last period during childbearing is the between pregnancy period. And I strongly try to influence people that between the period of your family planning when you're not pregnant and not breastfeeding, to go back on your medication therapy. Be very planned about pregnancy for somebody with FH is the best time, because even if I can treat you for 3 to 6 months to keep your LDL low in that time and then you decide to get pregnant, it's okay. You can do that, but that's at least reducing the amount of time that you're exposed again to high LDL levels. So even if it's just for a few months, it contributes to the lowering of the lifetime cholesterol burden. Historically, statins were contraindicated in pregnancy, mostly from case series data that showed an association between first trimester statin exposure and fetal malformations. Now, I will say that was data from 2004. More recent data have not shown that there's an increased teratogenic risk to the offspring. And it may be that even some of the statins, particularly the ones that we consider hydrophilic, things like pravastatin, have not been associated with any such abnormalities. So, more recently, we've actually had the FDA actually requested the removal of the strongest recommendation against use of statins during pregnancy. And really, for the safety of all medications, there's only really one thing: bile acid sequestrants, or Welchol is the trade name, that's currently recommended to be used during pregnancy that can be used safely. So additionally, other therapies, as I mentioned before, is that women with FH can be treated with LDL apheresis, and that is not harmful to the mother or the offspring. So in terms of the other lipid-lowering therapies, we definitely have less information, right? We've had statins around for a long time, and we now have many novel medications that patients with FH may be on, things like PCSK9 inhibitors specifically, but even inclisiran, and bempedoic acid are new drugs. But all of them are contraindicated for pregnancy. And it's not that there's human data, but that there's potential fetal harm based on animal studies. And so they are contraindicated, these newer medications, as well during pregnancy. Again, these are conversations to have with your physician who's managing your FH about the risk versus benefit. And specifically, I'm probably talking to the women out there who have homozygous FH, that they should be talking about, did they already have a cardiac event? Is their own risk elevated now if they go off statin therapy? Because again, some of the statins may be safely used, and we know that. We have registries of patients who've been exposed to statin therapy despite all our recommendations, and maybe they didn't know that they were pregnant yet, or their risk was just so high that their physician and them already made the decision to continue the statin therapy, and we don't have data that it's been that harmful. That's why the FDA removed that strongest recommendation that statins could never be used during pregnancy. We know they can be used, and if they need to be used, they should, but it's a risk-benefit conversation to have. So if somebody's pregnant and is looking for supplements, I really don't think that there's much out there that you can take that will lower your cholesterol. In fact, I advise people to stay away from supplements, specifically because we don't know, even our supplements aren't well followed in the United States. And so sometimes what they're labeled as isn't actually what's in the container, and potentially harmful to the individual. Don't think that because it says over the counter that somehow it's safer than something that is prescription, because I think that really is somehow a myth that has been perpetuated in our society. But I think the things that you can do, higher fiber in your diet, that can be at least one way to keep cholesterol low. Try to keep a plant-based diet as much as possible. Again, plant-based proteins are healthy for you and healthy for your fetus. You don't need to have meat sources of protein necessarily, and especially the fatty sources, again, you want to be eliminating. And again, going more plant-based. Being on a plant-based diet doesn't mean that you're only eating plants. It just means that the majority of your diet is plant-based. And so doing things like that, increasing the fiber in your diet, as well as making sure your diet is incredibly heart healthy and low in saturated fats, is the things that I would recommend for you to do. Hormone replacement therapy, it's not necessarily, it's not indicated for the primary or secondary prevention of coronary artery disease. And it is especially not advisable for women with FH. So when treatment is necessary for a postmenopausal woman who has FH for the relief of vasomotor symptoms, it's important to talk about that again, about the risks and the benefits of what will happen if you're on hormone replacement therapy. If you already have cardiovascular disease, really hormone replacement therapy should be avoided. I actually always recommend non-hormonal therapies first. Things like gabapentin, duloxetine, those are other medications that can help reduce vasomotor symptoms. They don't increase your coronary artery disease risk. They don't affect your cholesterol. And so I actually try to work with an obstetrician to use those first before we use any version of estrogens, if that's possible. Well, the guidelines currently say to stay away from estrogen if you have, if you already have heart disease. So from a secondary prevention point, it's not beneficial. From a primary prevention point, there's not good guidelines per se. We just say that you shouldn't be using hormone replacement therapy to prevent heart disease. But certainly for somebody who's going through symptoms, we don't want people to suffer. So again, my recommendation it's a conversation with you and your cardiologist about what's best for you. If you already have cardiovascular disease, though, they may even ask you to avoid topical estrogens if possible. So there are other choices out there. Things like gabapentin, duloxetine, they can reduce your vasomotor symptoms, but they don't increase your risk for coronary artery disease. They don't affect your LDL cholesterol. So these are discussions to have because people are across the spectrum. When you have FH, you may not have heart disease yet. You may have already had a heart attack or stroke. Depending on where you fall in that spectrum, we're going to have different recommendations. For some people, cream is okay if it's necessary and if it's more effective for you. We don't want women to be suffering. I think this idea that women need to suffer through vasomotor symptoms during menopause really needs to go away, but we really need to find the right medication for the individual. Yeah, so research is happening. I think we should be positive about that we are doing more research on FH. We are doing more research on Lp(a). We are at the earliest stages of really understanding it, and the new research that's going on is going to save lives of both men and women. The problem in research, though, is often an under-enrollment of women into our trials. And there's a lot of reasons for that. Historically, we've left women out of trials. To this day, we will publish things and we'll see the percentage of women included is small. And yet I started this whole conversation telling you that FH happens in both men and women in an equal proportion. So we really should be studying men and women when we're studying FH. And so we need to get them both into clinical trials, and particularly the questions that we have about women that are unique, related to pregnancy, related to menopause, related to breastfeeding, they need to be done. And when we do study women and include women in trials, we must do sex-specific analysis. We should report it so that we know what did the study, even if that wasn't their question to look at sex differences, they should still do that analysis to help us think about maybe things are working differently in women compared to men. And for women specifically, as I said, there's female-specific life stages, things that don't happen to men. Things related to the menstrual cycle in women, pregnancy, breastfeeding, menopause. What happens to the lipid levels at those times is important, and we need to investigate whether these life stages in women impact their future risk or not. This is the problem. This is the reason that there's not guidelines specifically for FH related to breastfeeding or FH related to pregnancy. It's because we haven't done the trials on them. So for you, those of you listening to this who are women, if you hear about trials that involve FH, try to be part of them if you're the right candidate for those studies. We need women in these trials. We need it so that we know how to treat the next generation, let alone the current generation. But our hope is that we'll learn more for the future and be able to treat women safely. I think that is, the problem in so much of our studies. We've had some really great studies, though, recently that actually did involve 50% women. Just to give an example, these recent studies on bempedoic acid actually were 50% women. And that makes a big difference for us when we treat women. I almost exclusively treat women. And so knowing that drugs are effective in the population that I care for is really important. And so much of cardiology and of medicine has been focused on men as if women are a special population. Yet women are 52% of the population. We are the majority. We deserve to be studied. I just want to remind you that if you personally need help on your healthcare journey, you can contact the Family Heart Foundation Care Navigator. Well, thank you everyone today for joining me and giving me your questions in advance for me to answer them. I strongly encourage you to learn more at familyheart.org. That's where I send all my patients that I meet with FH and elevated Lp(a) so that they can learn about their disease.